Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the chat pod located to the right of your webinar platform. You may also download a copy of today's slides using the Files pod located below the slide presentation. It is now my pleasure to turn the conference over to today's first presenter, Chris Hund.
Thank you so much. Hi, everybody. This is Chris Hund, Senior Director with the AHA Center for Health Innovation and Director of the AHA Team Training Program. Very happy to have you here today for the May 2021 monthly webinar. This is on a culture of team-based care, improving value, and I think it's a very exciting webinar today. We're going to try things a little differently, so there'll be a lot of speakers and a roundtable discussion, so I very much hope that you enjoy this. Thank you again as well to our sponsor, Quality Reviews. You'll be hearing from them in a bit, but it's very, very nice to have a sponsor, and we appreciate them very much. Some rules of engagement. So the audio for the webinar can be accessed in two different ways. You can listen through your phone. If you do that, make sure to mute your computer speakers because otherwise you'll get a weird echo. Or you can listen through your computer. That's a good thing to do if you have a strong internet connection, although I know some folks sometimes in hospitals find it easier to listen through their phone. All hyperlinks on the screen are active. If you click on them, it will just open up something in a browser so that you can look at it later on. We also have the slides are in PDF form in the file pod that you see on your screen right now, so you can download the slides too and check out things later on. We'll do a Q&A session at the end of the presentation as well. The way we like to do this is that you write questions as we go along, and then we will do a curated Q&A at the end. So please submit those questions as we go in the chat area. To get continuing education credit from our partners at Duke Health, you need to create a Duke OneLink account. If you've already done this one time before, you don't need to do it again. But if this is your first time with us, you will need to do that. So the steps are on the screen right here. There are also instructions in that file pod that you can download. The most important part of this is texting the code that you see on the screen within 24 hours to the number you see on the screen. We'll make sure to throw that code and number up again at the end of the presentation, and also they will be in those files that you could download. Some upcoming events to let you know about. So we have some webinars on the horizon here, as you can see. So 3 webinars, 2 more monthly webinars, and a bonus webinar in June. So please consider registering for all of these. All of them are free as normal and covering a lot of different topics, as you can see. Our partners at the Physician Alliance in the AHA are doing a virtual course called Recover and Renew, Virtual Resiliency Program. And so this program is all about supporting clinicians in light of what's going on with the pandemic and what has happened, and helping them really reconnect with their source of resilience. You know that resiliency is a big thing for AHA team training, so we're very happy to let you know about this course from our partners at the Physician Alliance. So register today with that link. This is for members of the American Hospital Association, so before you do that, you'll have to confirm whether or not your organization is a member. Normally somebody in your leadership will know that. Also, online community platform Mighty Network is, as always, growing and having more and more content on it, more and more exclusive content, so it's free to join, so please go ahead and do that today. Another thing to tell you about is the American Hospital Association Advancing Care Conference. This is Team Training's new conference. So if you have been a big fan of attending the last almost 10 years of team training national conferences that we've put on, that's what this is. So we are transitioning to a new name this year. We're growing. We're adding more content on resiliency and education and patient safety and quality, as well as teamwork and communication. So that's why there's a name change. Check out the website for more information. We'd love to have you come and present and be a part of this brand new, fun conference experience. It's now my pleasure to turn things over to Jill Yarbury, who's the VP of Patient Experience with Quality Reviews. And Quality Reviews is our sponsor this month. So Jill, take it away.
Thank you, Chris. Hello, everyone. Welcome. As Chris said, I am the Vice President of Patient Experience for Quality Reviews, and we're actually delighted to be a sponsor again today with AHA. And I'm going to spend just a really couple of minutes just explaining a little bit about Q Reviews. So we actually are a digital solution. We offer real-time platform that helps your organization garner patient and employee feedback truly in real time. Chris, do you mind to advance?
Of course.
And how we do that, guys, we actually send a text message in real time immediately following an episode of care. This is sent directly to a patient's smartphone, and it gives them the opportunity to answer questions that are directly related to their experience. And then that information and data actually comes to you in real time. You could literally watch a patient answer a survey and see their answers on the screen in the dashboard that's being shared, which would be a proprietary dashboard for each of you. One more slide, Chris. Guys, I wanted just to show you a few of the clients that we work with. Probably there are a few of you on this call today because I know we've got several folks on the call. If you don't see your name up here, we would love the opportunity to learn a little bit more about your organization and how you're currently looking at correlations between your patients and your employees and help you address, those specific needs. So my information will be actually on the next slide. If there's in any way that we can help you moving forward, we would love to, and I would love to learn a little bit more about you. And again, it's our pleasure to be the sponsor again today. We've had some great opportunities to sponsor a few of these prior to this, and I'm sure we'll be here again soon. I'll turn it back over to you, Chris. Thanks again.
Thanks so much, Jill. And yes, everybody, please, if you're interested, get in touch with Jill. Check out the website. It seems like a really exciting service and product that Q Reviews does, so lovely to have them with us again today. Okay, so now I get to the meat of everything and introduce today's presenters. Like I said, we got a big group and an interesting way of doing things today. So today we have Dr. Thomas Gluck, who is a professor and Director of Behavioral Health and Vice Chair, Department of Family and Community Medicine at Creighton University School of Medicine in Nebraska. We have Christy Brandon Kiefner, who is physical therapist and also an assistant clinical professor in the same department, Family and Community Medicine, also at Creighton and also at Catholic Health Initiatives, Creighton University Medical Center. We have Todd DeFries, who's the Vice President of Operations at CHI Creighton. We have another slide, too. Like I said, we're very excited. We have a lot of cool presenters today. We have Amy Mugehe, who is Dr. Mugehe, who's professor and Bob Fair, Director of Clinical Learning Environment at the same department at CHI Health at Creighton. And last but not least, the moderator for today's group is Julia Resnick, who is a Senior Program Manager here at the American Hospital Association. So without further ado, I'm going to turn things over to Julia.
Thank you so much, Chris, and hello, everyone. Thanks so much for joining us today. I'm so glad to be here with all of you doing this webinar with the team training folks. So at the AHA, I work on the Value Initiative, which is the association's strategic effort to advance value and affordability in healthcare. Our work is guided by the value equation that you can see on the screen here. So when we talk about improving value, we are talking about strategies that improve outcomes, enhance the patient experience, and reduce cost. So there are a number of value-based care delivery strategies that hospitals and healthcare organizations can adopt to help them advance on their value journeys. And while there are many strategies here, and many more than you probably want to read in this small text, I think the key takeaway is that every component of the healthcare system and every person in it can contribute to improving value. And as you'll learn in the next hour, team-based care is most definitely one of those value-based care delivery strategies that impacts each component of the value equation. So if you want to learn more about AHA's The Value Initiative, you can check out our website, which is full of resources to support your value journey, including an issue brief on the value of team-based care, as well as resources on other team-based approaches like screening for social needs, integrated behavioral health, palliative care, and hospital at home. So without further ado, I want to turn it over to the team at CHI Creighton. We have a few learning objectives that you can see on your screen that we'll be going over in the next 45 minutes or so. But for now, I will turn it over to Todd, and so that he and the rest of the CHI Creighton team can give you an overview of their work, and then I will join them for a moderated conversation. Todd, take it away.
Yeah, we're so happy to have everybody on the call today. So just to give my role as an administrator is always to give the context, right? So University Campus was part of our organization's plan as we moved our academic medical center to West Omaha. So we were closing a safety net hospital down in a community, but wanted to continue to provide the key services that the community needed. Particularly for a part of town that was underserved. So really came together with our community to design and implement the services that we were going to offer at this campus. And then as we were going through the actual schematic design process, we took a pause because we really wanted to build the center around an idea of interprofessional education. And so we actually took about 6 weeks to look at how do we redesign this brand new campus so that it integrates not only each of our professions, but each of our learners throughout each of the clinical areas on the campus. Also as part of that, we were bringing together 2 historical clinics to create one new facility. And as part of that, we really wanted to look at how do we drive these historical clinic sites that have existed, how do we turn these into interprofessional collaborative practice, benchmarks that others can come to look at and see how do we do this really right. And so that is really kind of the basis on which we built our university campus of Creighton University Medical Center. And so not only family medicine, but the other services we have on site, and we'll get more into that here in a second, it's really all built around this idea of how do we collaborate to not only learn from one another, but how do we collaborate to better take care of our patients on a day-to-day basis. And with that, I will turn it over to Amy.
Thank you so much, Todd. I am so pleased and grateful to you all to be able to present with you today. So as Todd mentioned, we have a couple of organizations have come together, so Common Spirit Health and Creighton University. And for us, it has always started with the mission. And so mission statements for us are not just things that live on the wall, but it's something that's very much part of our culture. And one of the things that's interesting, and we'll talk about this more as we go through the program today, But it's very common for us in the building to not necessarily know who's employed by whom because we have such a shared identity. But if you look at Common Spirit, it's a commitment to the healing presence of God, particularly for the health of the people we serve and taking care of the vulnerable with attention to social justice. Similar, again, the mission for our academic partner, Creighton University, is the commitment to education of learners and healthcare professionals, advancing knowledge, and really this idea of comprehensive patient care. I am a family physician, and I was trained in the biopsychosocial model, and so as Todd said, when we transplanted the 2 clinics into this new university site with additional specialties, family medicine was an excellent specialty to bring that DNA, because the biopsychosocial model, we're intersecting with the community. This isn't just healthcare that's delivered within the 4 walls of the clinic or within the hospital, but it's what's happening in the community. And Cura Personalis is this commitment to whole person care, and so that's where our specialty and the locations that we're working in the hospital and in the outpatient setting and long-term care facilities, we were the sort of the initial DNA. So we have some, just kind of to talk about the clinical services that we are having here in the site. So we have downtown, midtown, North Omaha. We have a lot of patients we've picked up from that community, and so large employers. So we have Union Pacific and Gavilon Mutual of Omaha. So we have people who are coming from downtown. We're also the contract for the Creighton University Student Care Clinic. So you have young students coming in, and then we have also a contract with the refugee care to provide refugee care for the resettlement physicals with the Department of Health and Human Services for the state, and then also our commitment with other organizations like Charles Drew, our Community Health Center, the Homeless Center, and so being able to partner with all the different intersections that we're seeing. So next slide. I apologize. I see that it might be breaking up, so I don't know if that's me or on the other end. So I'll throw it to Dr. Gook to talk about some of our clinical outcomes.
Thank you, Amy, and I'm happy to be here as well to visit with all of you about our program. I want to talk about our clinical outcomes in just a second, but I want to just kind of put this in a time frame. We opened our clinic in January of 2017, and the year before that we were able to do some visiting about not only what services are we going to provide and how we're going to do that, and the process of building the building that Todd mentioned, but we're also looking at this as an opportunity to collect data. And so in our first year before we opened the clinic, I went back through a lot of our patient records from the 2 or 3 clinics that were merged into this university clinic and got data on our agreed upon outcome measures, which were ER visits, hemoglobin A1C, hospitalizations, and then patient charges. And we chose those because we thought those were consistent with the quadruple aim, which is one of the drivers of, theoretically at least from where we're coming, where we are looking to make an impact to drive the cost of services down and improve the satisfaction on the part of our patients. So by getting the outcome data baseline year, we then implemented the program, and we're going to talk a lot more about what the program is and how it was implemented. But after the first year, then in 2017, we then went back and looked at that same cohort of patients to see what was going on. And we published that paper in American Family Medicine, or Annals of Family Medicine, rather, and the references there. And we have a couple of other publications that we've done, and we'll have those in one of the slides at the end of the program today. But what we found was a significant reduction in ER visits, reduced hemoglobin A1C, reduced hospitalizations, and a significant reduction in patient charges. So we were real happy to see those, and it's really interesting that we got these kinds of reductions in a model or in a facility where most of our services were provided through a fee-for-services model. It was not a value-based model, unfortunately. We're hoping that we're kind of making the argument that we go to more value-based care types of arrangements. But this was done primarily in a fee-for-services model. And it was done in a residency training clinic. And so Dr. McGahey and myself and Christy Brandon, all of us are working with the family medicine residency training program, and we have a lot of students who come through our medical school and all of our health sciences schools, including OT, PT, and nursing and other schools that are involved. So while teaching and while doing this with students coming through and with a residency program and with a refugee contract where we have a fair number, probably 30 to 40% of our patients require interpreters, we were still able to get these outcomes, and we were really happy with that. So what we did from there then was to do another study where what we wanted to look at was these nice changes that we got from one year to the next. We want to see if those could be sustained, or were they just merely a regression to the mean, and these things would fall away year after year. Well, in the next study, we went 2 more years with the same cohort, and then we also added 2 other additional cohorts. So we wanted to sustain these changes, or see if we could sustain these changes, and see if we could also replicate them in 2 additional cohorts. And that study, we finished it up, and it's under the review process, and I'm in the last phases of it, so it should be in press relatively shortly, where what we found was we indeed were able to sustain those initial changes, and we were able to replicate them in the 2 additional cohorts. So we were really happy about that. We also have found, we didn't publish these data, but these are organization engagement and satisfaction among staff. When we first started our program, we were like in the lower third of the clinics in terms of engagement for the people who joined this university clinic venture. And then after a year of being in the new model, our engagement and satisfaction were, I think, number 2 in this system. So we saw significant changes in what is the 4th of the quadruple aim, which is provider satisfaction. So I'm going to stop there, and I'm going to turn this in over to Christy.
Christy,
I'm sorry.
maybe muted.
I guess I'm supposed to talk about this slide first. The model that we're looking at is obviously interprofessional education and collaborative practice, and the definitions that we use for interprofessional education and collaborative practice come from the World Health Organization, and you can see these on the screen here. This was one of the drivers, as well as the quadruple aim, in terms of the approach that we wanted to take. And then we looked a lot at team-based care, and we're going to be talking some more about that. I was fortunate enough to go to a national conference where Eduardo Salas, who does a lot of team-based care, was presenting as well, and we use an awful lot of his material as well. He's got a new book out called Teams That Work. He and Scott Tenenbaum, and we've used a lot of their work on the 7 C's regarding team-based care as well. So with that, I'm going to turn it to Christy to kind of flesh out some more of what we've done with the teams.
Thank you, Tom. This is Christy Brandon Kiefner. I'm a physical therapist and grateful to be speaking with my colleagues here today. I think I also am a representative of the support that our leadership offers for champions of interprofessional education and collaborative practice at all levels. So oftentimes, as Amy McGahey says, we've been to the promised land, and we believe in this type of care and this great work that we're doing. So I'll share some of the team strategies that we use on a daily and weekly basis. We'll start with rounding. So rounding can come in a few different forms, but it's that quick follow-up with your team member. It could be the attending. It could be the different providers that are working with our patients. But that early interprofessional collaborative rounding that helps to prevent safety issues. We have collaborative care planning. Initially, that started once a week. Thursday was our day to get together with our larger interprofessional collaborative care meeting. Roles and responsibilities were actually given to each member at the round table. We had a representative from each interprofessional care team that is on campus, and we also had representatives from Creighton University's Center for Interprofessional Practice Education and Research, and that was integral for the ability to assist with bridging the academic and the clinical and what we are doing to create solutions for our complex patient cases. Initially, Tom was the one that would tap our residents to present at these collaborative care meetings. It has since evolved to the ability for any interprofessional care provider to bring a patient of interest to the table and talk about how we can help improve their care. We also have pre-visit planning that happens in the morning and respective afternoon for our medical providers, and the interprofessional care members are able to meet with that provider if they have an MA and review their morning or their respective afternoon patients to identify, is there anything that might be missing? Could they have another referral to another provider? But it just allows that extra few minutes that after huddles, our interprofessional collaborative care team can meet with our providers. We have warm handoffs. So as you saw with Todd's first slide, our building is small enough to allow quick, logistically quick warm handoffs. So for example, the rehab department is on our respective first floor, and our medical providers can walk a patient down, introduce them to the greater rehab team, let them know where they will be doing their therapy, whether it's occupational, physical, or speech therapy, and they can meet the team so they feel welcomed. We found that actually improves the patient return rates. We feel like it improves the patient trust, that they really feel like they have a good care team supporting them throughout the building or their patient-centered medical home. So those warm handoffs happen all around our campus to help the patient feel supported throughout their time. Teamlets. This is something that has happened organically. Tom, you can feel free to add in about teamlets, but teamlets are these offshoots of the larger collaborative care team that organically now form to meet, to update on how a patient is doing. And I would also say the size of our building also allows for these teamlets to organically form because we see each other face-to-face on a daily basis, and that really matters, and it seems to improve the communication for the care of the patient. As a result of these teamlets, we found shared decision-making organically happens. This is like teaming on the fly. You're able to create and offer opportunities to care for that patient or to help them with the care plan to make sense. So we're able to offer lenses from different professions. I'll move forward to the next slide. We often say that we represent our larger community of interprofessional care providers here. So although we are here speaking to you, we're grateful to be representing everyone here that is on this campus. And initially, we had the providers that you see present, and we have grown since based on the needs of our patients. So we now have social work, our speech therapy team, and we have specialists who also work with our team, such as cardiology. They're also part of our team. We also frequently collaborate with our, sure, please.
Yeah, Christy, if I can just jump in just to give an example. Christy and I work a lot together with patients who have chronic pain, and I have the luxury, as a psychologist, I do a lot of work with our chronic pain patients, and I probably have 50 or 60% of my sessions in physical therapy in the space. So one of the key concepts I'm trying to get across to patients is that their pain is no longer a signal that they're doing harm. They hurt, but they're not doing any harm or damage. And I can go in real live situations while they're in physical therapy and do that while they're doing reps, like if they have to do 10 and they want to stop after 5, I can remind them about that they're not doing any damage, and then they're willing to go on further. And in real time, we can deal with a concept that would be hard for me to get across to them sitting in my psychology office, but on the real floor where they're doing the work, I can get that across much clearer.
Yes, thank you, Tom. And that brought a couple other examples to light. The opportunity to be together in this environment on a regular basis, attending huddles, attending care collaborative planning, that's also created the opportunity to build trust with each other. So for example, in rehab, we always say vitals are vital. So if we're taking blood pressure as just one example, and we need to get a patient in to be seen with their primary care provider that same day, our providers can make it happen. And so it's so wonderful not to feel like you're on an island and you can't get your patient that may need to be seen in that same day. And so not only can our patients go right upstairs, we can also ask if an attending can come downstairs to assess their patients. Interprofessional collaborative practice, then and now, these are some of the frameworks that have been utilized as helpful as we've continued to evolve. And beginning, actually, let me start with how we began. We are community and population-oriented, patient and family-centered. So these interprofessional core competencies that you see down in your left-hand corner of the screen are key for all of our providers. We also have really appreciated what the National Center of Interprofessional Education and Practice has put out, really linking the importance of what we are teaching in the classroom to what we are doing in the clinic. And so we really believe that the strength of what we are doing is strengthened because we have this strong partnership with our health system. And so the learners are literally able to come across the street and see interprofessional collaborative care in practice. We are also, this interprofessional learning continuum has also been helpful to understand that the trajectory of learning starts in the foundational education and continues throughout all of our practice, even once we have completed our graduate education. And so one of our mottos that we'll talk about next is everybody teaches, everyone learns. And we see the enabling and interfering factors as opportunities to improve the work that we are doing. So I think it's good to be aware, but also see these as opportunities for moving forward. The health and system outcomes are also opportunities for tracking, as well as our learning outcomes. When we do all of this well, it's easy to meet the quadruple aim. And Tom mentioned some of the statistics that support the belief in that what we are doing is really the quadruple aim. Initially, we were looking at meeting the triple aim, and as a result of the good work and the collaboration, we've met the quadruple aim of decreasing clinician burnout and improving provider satisfaction in the work that we do every day. So these are the mottos, and it's important to say your motto and allow not only your providers to believe it, but your learners that come into your environment to feel it. So we always say, and we hope it's echoed across the campus, that everyone teaches and everyone learns. And by saying this, it allows the learners, as well as all of our providers, to feel, we hope, a sense of psychological safety, so that everyone can feel that they can speak up if there's any safety concerns, that what you're saying and what you're working towards for the patient matters. So everybody teaches and everyone learns. And we often say assume positive intent, because when you bring providers together from all different professions, you often have to remember that we are all here for the betterment and the reason for caring for our patients, and remind each other that we are all supporting each other. So those are our mottos at University Campus. And then I'll pass it on for Interprofessional Education and Collaborative Practice, the teaching mission.
So we've talked a lot about how the culture has come together, but we just wanted to emphasize again that all of this is happening in one of our major teaching locations within our integrated health system. And so this site provides an opportunity for all kinds of students and learners to be in the location. Our family medicine residency has been around since 1970, And we have a lot of first and second year medical students who come into the clinic and they're able to see ambulatory care delivered in a very specific way. And these are students who, this is their ambulatory experience, not necessarily primary care experience, but we see that these concepts can be similar for colorectal surgery clinics. One of my colleagues in an outpatient colorectal surgery clinic was talking about how they've needed to increase their team-based care in the ambulatory setting, because in the inpatient setting, you have so many resources that they're available for you, and so how do you replicate that for the team? And I wanted to say one more thing about this idea of culture of support. We've talked about how we're able to be a partnered team in support of the patient, but we're also a partnered team in support of each other. And I know that I know your next presentation is about resilience, and so many of us are talking about resilience and trying to stay together in these really difficult times. But sometimes one of the most effective tools is having another professional with a different perspective that can just affirm for me and say, yes, this is really challenging, and what you're doing is exactly the right thing, especially when you're talking about patients with chronic pain, patients with complicated social issues, and patients who have very complex diseases. And so that's really an important, and also mental health is our other variable that we see that increases a lot of our utilization. And so being able to have that team together is not just supportive for the patients, but it's really supportive for the team that's helped us maintain our resiliency. And so we see that we're being successful. And one of the axioms that I say within our department, and I tell my learners often, is that I'm training you to be disappointed when you go out into practice. Because what I have seen is that there's a lot of places where we're not achieving the triple aim, or definitely not even the quadruple aim. And so what I want them to be are agents of change. And so that Jesuit practice of going out and setting the world on fire, how can they be agents of change that they've seen this done really well, and that they can go into a new community and they can actually build a similar team. So this is a picture of some of our people happily shared together. And I think,
if I could just jump in, Amy, real quick, I wanted to go back to this to our mottos and just maybe let people know a little bit more about where these came from. Early on, when we first started, because we're a teaching facility, some of the staff had some like the front desk people and the MAs, for example, were a little intimidated by the idea of teaching medical students and residents, and so we really spent a fair amount of time in our first months really orienting them to the idea that they are really teachers. And so we want the front desk and the people who screen people for insurance to teach our medical students what that whole dimension of healthcare is all about, and how someone having insurance or not having insurance makes a big difference. And so there's a richness that comes from all of our staff who have to do the teaching, but we are all learners, so no matter what your degrees are, you can always be learning something from somebody else. And the assumed positive intent came really out of our work with our business college. We have a section of our business college that does conflict engagement and conflict management, and they were really instrumental. We had a small grant that was helpful to get them to help us orient our new team when we opened the building, and this was one of the mottos that came out of our idea of conflict engagement. We can certainly disagree, and we as different disciplines, we can look at the world very, very differently, but what we always want to do is assume that the other person's intent is proper and is in line with our mission and wants only the best for the patients, but we can disagree with maybe where things need to be done. And what we want to do then is not avoid conflict, but we want to embrace conflict and allow it to be there so we can work our way through it. And as a psychologist, I always work with my patients who are anxious about the idea if you continue to avoid, you're only going to make the problem worse. You have to confront it and work your way through it. And so this saying, I think, has really been helpful, and we refer to it often in our huddles or in any other trainings that we do.
Thank you, Tom. So well said.
Julia, I see there's a question in the chat that I'd like to address from, it looks like Joy Cherian, and it's what are the most challenging gaps that you've noticed in the collaborative care model? And I'm guessing you're talking about with this model here. I would say that one of the biggest messages that I hope that you all take away from this is just co-locating people together is not the same as integrating them. And so co-locating is nice, and it's nice to have that adjacency, but I have to have the right personality and not even personality, but I have to have the right personal motivation to go out and interact with other individuals, and then I also have to have the systemic support for that. So I'll say with the behavioral health, we're very fortunate in our system that our behavioral health, integrated behavioral health model, they are not required to be on a productivity within the primary care clinic. And so there's a freedom for them to be able to come in and be part of the primary care or even accompanying patients down to the emergency department, but not just needing to necessarily be in their own one-on-ones. And so I would say having all those pieces where you have the personality that wants to be integrated is great, but you also have to make sure that the pathways and the support are there. I would say it's also been very nice that people have wanted to join us. So for example, with the spiritual, CHI has a chaplain residency program, a chaplaincy education program, and they were in talking with their faculty, they were recognizing that so much of their training is in the inpatient setting, and they wanted to have more training in the outpatient setting. So they actually came to us and said, how can we support you? How can we learn? What can we do? So I would say that's, in terms of the gaps, it might vary from year to year, but it really comes down to just putting people together doesn't necessarily integrate the team.
I'm going to go down to the one of our last slides here after our team. These are some references that you all might want to just take a look at. These are some of the publications. Christy was the first author on a nice paper that was done a couple years ago on really looking at what the interfering factors were and the factors that are helpful in terms of dealing with our model, and give some of the background about philosophically where we come from and how our organization's missions match up and how they drive the model of teaching and collaborative practice that we wanted to put in place. So I'll let you kind of look through those. The two papers that we've done now on outcomes are also included in here, and then some other kinds of papers. This was our grant that helped us to fund our conflict engagement work.
Wonderful. Let's switch over to our moderated, curated Q&A. I'm going to have our speakers turn on our cameras because as much as I like seeing your slides, it's fun to be able to see each other's faces if we have to be doing this in a virtual world. So I'm going to give it just a moment for everyone's cameras to turn on. And I'll also encourage our participants to ask any questions that you have, but as the cameras are coming on, I will take moderator's prerogative to ask a few of my questions, since I always have several of them, because you all are inspiring and I am excited about what you do. So I see a few of you are still coming on, but I want to start with this idea about like how you demonstrate the value of team-based care, because I know one of the challenges for healthcare organizations that are looking to make this shift is justifying the value, because it takes investment and training on the front end, and our leaders want to make sure that it's really worthwhile. So Tom, you touched on your research, which had really great results. So I'm wondering what you think are the most compelling arguments that clinical leaders or other hospital leaders could make for having interdisciplinary team-based care.
Well, first of all, I think it's the right thing to do, because what happens is patients get the best quality service, and it's not splintered and it's not coming in silos where you have the lack of integration. Even in a building where you have co-location, like Amy was talking about, it still requires the integration. So I think having that in place. But you're right. We have to have outcomes, and that's why we put that component into this. And we wanted to look at are we making an impact? Now, Don Berwick, who's the author of the Quadruple Aim, talks about the ideas that really we have a lot of data now that suggests that the Quadruple Aim is really the way that we need to go. Now it comes down to we as a society, I think, about do we have the will to start practicing in this way? And so that's a much bigger kind of existential question that I think we as a country have to look at, because I think we can kind of keep reinventing this wheel by demonstrating good outcomes, but if we don't have the will to change, then I'm not sure how much further we're going to be able to go.
Mm-hmm. Anyone else want to weigh in on that?
I would just like to add, I'm looking at, on my wall here is a cutout from the Omaha World Herald that after Tom's article was published, the Omaha World Herald put us on front page above the fold, and the actual title says, Teamwork in Care at Clinic Saves $4 million per year. So there was not an attention to the patient satisfaction or the quality of care, but it was the financial piece. And that is, again, I'm still sort of waiting for my check from those payers for all that money that we saved up. But that's really the fundamental thing that we're trying to get back to, is that when you look at the Quadruple Aim, when you're attentive to the Quadruple Aim, these are the kinds of models that achieve it. And it's not necessarily always glamorous, but it is nice to be on the front page for good things.
Absolutely. So by now, I suspect that we're all convinced about the value of team-based care. So I want to talk a little bit more about like implementation and what it takes. So for healthcare organizations that are out there who are looking to make this kind of transformation, what do you see as the key elements to successfully implement interdisciplinary care teams? And Todd, I'll start with you on this one.
Yeah, I mean, I think to start with, you have to have leadership commitment, and that goes all the way to the top. I mean, you have to have commitment across your entire organization that this is the right thing to do. They see the value in it. Granted, you're going to have some folks that are going to see more value in different parts of it than others, but I think you have to have an intentional commitment to say we're either going to do a pilot or we're going to focus on doing this, wholesale. And then really for as you're looking at the clinical enterprise itself, you have to have champions across the board for all your various professions. You really have to have people who not only want to work this way, but are engaging and want to partner and build teams beyond just themselves or their profession. That was so critical to what we do. I think there was probably one service the first month we were open where everybody said, well, is this really fitting with the rest of the dynamic? And so we had a very pointed conversation with that group, and now they are probably the most engaged of anybody that's there on the campus. And so it's just about getting everybody's buy-in, having those champions that understand what their role is in the process and how that role can change depending upon what part of the clinical environment they're in. I would say, as we just pointed out, the financial incentives are always going to drive how committed an organization is to any type of project. And so I would try to align your financial incentives as closely as possible to the model that you're trying to implement. So, CPC plus, risk-based care models, how do we either partner with payers or partner with the government around doing some innovative work where not only is it going to be rewarding from the standpoint of the clinical and quality outcomes and from the patient satisfaction and the provider satisfaction, but it's also going to be financially motivating as well in terms of how much the organization either saves or makes off of the endeavor. And then last would be just to focus on the team. And so how do we build teamwork and build those competencies around teamwork as we go along? Because we all know that a high-performing team doesn't happen right away, and so it's what type of education, what type of encouragement, what type of training do we need to do in order to make sure that we can build high-performing teams as we go along. And I'd open it up to my colleagues just if any other thoughts they have.
Yeah, I'd like to just piggyback, Todd, on what you had to say about finding the champions. You really got to look in your organization to find people who are really committed to this kind of integrated teamwork cause. And we had some people who were kind of not chosen, but were kind of folded into the new clinic. And what we found was that some of the people found that environment was really not their cup of tea, and that was okay. That was really okay, and they chose to go on to do something else. I recall one person who's currently on staff did not embrace the model at all, and we had some real struggles with that. And but it's interesting. She has now come around, and she is one of our leaders. I mean, and she's one of our next generation champions. So just a matter of kind of either you have to choose for this, or you have to train for it to make sure that this can happen.
And I tapping into everybody's to the staff and to the employees. Higher mission has been really key, and so whether that for some of the people in the building that means that we get to take care of refugees, for some of the people in the building it means I work with learners, but it really becomes a community effort. We have a community garden that was started. Upstairs we have sort of a mini food pantry, and that's all done by the staff. That's not done by the leadership. And so tapping into people's mission and commitment to the people we serve has been, I think, one of the pieces of magic in our sauce.
Speaking of the magic in the sauce, I feel like we're dancing around the culture issue, but this is one of those things that comes up all the time, and I really want to dig into it because you guys seem to have figured out how to develop and sustain this culture of team-based care. So, like, what does a culture of team-based care look like? How would you describe it?
I can give you a real specific example of it, and that has to do with our physicians. As staff members, we all kind of got the idea we need to be team. But when our physicians come to the huddle every day, they're there. When our physicians ask for advice on topics, their leadership makes a difference. So I think there are a lot of different kinds of programs like team steps and conflict engagement kinds of things. And there's a lot of these kinds of programs that are out, which are wonderful and great. But I don't think they're always sufficient, because you've got to have the role modeling that the great concepts that are being presented there are done by all of us at whatever level, and that's why I think our physicians, when they embraced the model and they didn't see themselves any different than anybody else in the clinic, that made a big difference. And so you break down some of these hierarchies that can get in the way.
Oh, and Tom, I think that's a great point. I mean, it's about how do we get rid of some of the ego and some of the hierarchy that exists within, I mean, we have a historical system that has been built upon hierarchy and ego for 100 years. So how do we begin to break that down and really focus on how do we get the ego out, how do we get the hierarchy out, how do we focus on anyone can step into a leadership role at any given time because they have the expertise and the knowledge in order to be so. And that's really where that culture starts, is everybody recognizing that I don't know everything. Everyone in this clinic knows something that I don't, and I'm recognizing that, and I'm willing to take that on. So, I mean, really a true humility to understand that my part in the greater whole is to act as a leader sometimes and sometimes not.
Christy, Amy, anything you want to add on?
I would also say, you said, what does it look like? When you come onto our campus, you also see smiles, you see nods, you hear laughing, you feel those good feelings of collaborative care when you enter the campus. And so I believe you see it, and I believe you feel it when you come to university campus too. So we welcome visitors.
That's wonderful. So how do you build that type of culture, and then how do you sustain it?
It is daily commitment. It is an everyday job, and you have to have an infrastructure that will be attentive to renewing this. And I think that that's one of the advantages about the academic center, is that every July we're graduating old people and we're bringing in new people, and so we have to rebuild this culture every single year. And I think that actually does require us to be attentive to it all the time. I think that we have the ability to respectfully support, but also call each other out when we're not living our mission. And that's helped us identify when some people have been in distress. And, with COVID, this has been extremely important that we already started with an environment where our staff members trusted the leaders and the leaders trusted the staff, so that when we were getting all kinds of, conflicting information, and this is how we're going to do it today, and then tomorrow we have new information, everybody still stayed together, even though it was tough. And so it has to be from the top to the middle to the bottom, and it has to be every day.
We've also found it important to, as Amy said, we have to redefine this every year for our learners. And so allowing our interprofessional collaborative care team members to recognize what they do and what their team brings to the greater team. So during huddles for 1 week, each interprofessional care team has the opportunity to say what they do at university campus and how they can help the greater team. So that opens up opportunity for individuals to ask questions, to learn something that they didn't know, and also allow the learners that are cycling through university campus to have an opportunity to learn while they're here too what other providers can offer.
The other thing that we really want to do is we want to reinforce the culture. And so one of the sections of each of our huddles is a recognition. And so if someone has done something or stayed late or did something extra, that gets recognized and their name gets on the board. And we do that with each huddle. The other thing that's really important, as a psychologist, I've studied a lot about reinforcement theory. And one thing we know is that for every one time you correct someone, you need to be reinforcing them positively at least 4 times. So that's true for staff interactions. It's true for parenting or grandparenting or marriages. All of these things can be really successful if you reinforce the proper behavior for every one time you correct.
Love it. And I know we're short on time, but I want to touch on the training and the learners. So Amy, can you talk a little bit more about how you're embedding this team-based care model into your training and what your vision for the future is?
That's where the Center for Interprofessional Education and Research has been really helpful. And so Creighton University has 9 health profession schools, and there's sort of this organization that manages both making sure we're hitting all of our educational requirements, but then also giving us an opportunity to do some of the research, and that's where some of this funding and different pieces have been supported. But whoever your educational partner is, they should have some forum where there's representation from lots of different disciplines and professions that are all there, and then they should be invested in your site too, because that's one of the places where we do want to see more investment from some of the other schools, because right now it's the schools that are associated with CHI, because that's, in terms of funding and things like that, and so making sure that you have a place for other schools and learners to be there. But it's, it's pretty much all educational health professions have some interprofessional education within their curriculum, and so really kind of tapping into that.
And I love the idea of your students being agents of change to bring this across the country wherever they go after this. So I realize we're reaching the top of the hour, and to our participants, I'm sorry we don't have time to take all of your questions, but I need to turn it back over to Chris so that he can close out our session. But I want to thank all of you all for joining us and inspiring everyone. You do such amazing work, and it's always such a pleasure to talk with you.
Thank you.
Thanks.
Thanks so much, everybody. That was wonderful. I hope everybody enjoyed having that round table. It's a lot of great discussion there. So some final reminders. We take our evaluations very seriously, so please complete the evaluation that will be sent to your email shortly. We always look at that every webinar. to do that continuing education, which is really important. If you want that 1 credit hour from Duke, download the instructions on how to do so in the file pod and text the code you see on screen within the next 24 hours to the number you see on screen. Okay, without further ado then, I'd like to thank everybody for attending today. I'd like to thank our great presenters for presenting. I'd like to thank Quality Reviews for sponsoring this, and thank you all for attending. We'll see you next month.
Thank you, ladies and gentlemen. This concludes today's webinar. You may now disconnect.